Hello, hello, my friends. Okay, let's see. We're live. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, November 2nd, 2025. Like, wow. Time just feels like it's flying by so quickly. I hope you guys had an absolutely wonderful Halloween. Icy friendly, no flares. Hope you had a wonderful chance to spend some time with family and or friends and going out and enjoying what was an absolutely lovely night here in California. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. Every Sunday, I try to do a live support group meeting for patients who are in need. My goal here is to educate, to inform, to empower, to show you that there's hope, to show you that you're not damaged goods. Like if there's just like one message I want you to get whenever you watch me or if you're talking to me on the phone, that this is not your fault. You have done nothing wrong, no shame, no blame. If you struggle with pelvic pain, if you struggle with bladder issues, if you struggle with prostate issues, bowel issues, whatever, there is hope. You are not alone. My goal here is to try to open some new doors for you, to give you some new things that you can explore, to help you work more effectively with your doctors, to give you new questions to ask your doctors. And of course, our challenge here is that there not a lot of doctors really are that interested in working with IC right now. They're just not. You have to remember, okay, urologists or surgeons, the doctors in medical school who are attracted to urology are attracted because they are some of the best surgeons out there. Because urology, surgery involving the urinary tract and the prostate, etc., it's very, very intricate. And so a lot of urologists who come into this field do it because they want to operate. And guess what? They don't operate on IC very often. So there, I mean, I've had urologists right now, I mean, tell me that they don't want to work with IC patients. They just want to do surgery. And the blessing here now, I get a lot of patients who call me who say, in fact, I was working with a patient on Friday who was saying, I don't know who to see. I don't really have a good urologist near me. And my answer back is, you might not need to see a urologist. This is where phenotyping helps. Because if you have pelvic floor driven symptoms, and your primary point is going to be a physical therapist. If you've got estrogen atrophy and that's driving your symptoms, your primary point is going to be a gynecologist or a urogynecologist. If you've got recurring infections and you're female, the odds are you could still potentially be cared for by a gynecologist. Men don't really have as many options as women do. For men, their only option is really their primary care provider and or a practicing urologist, whereas women, we've got a few more options out there. So this is where your phenotype really matters, because what broke the IC patient community is this assumption that everybody had an incurable bladder disease. I mean, when I was diagnosed 32 years ago, that's what we were all told. You have an incurable bladder disease. I had a doctor say to me, you will always live with pain. This is your life. Get used to it. You have something that we cannot treat. And of course, I've shared this story before. I went and he said, you will forever be a burden on your family. Well, let me tell you, that really got my ire up. I stood up and looked at him and I said, I have 3 college degrees. I will prove you wrong, you son of a bitch. How dare you say that to me? And I went home and I started studying. And I did prove him wrong. Absolutely 100%, because I absolutely got better. But fundamentally, we were all told that we had an incurable bladder disease, often for decades. And many patients took Elmeron for decades. Many patients did bladder therapies for decades. And guess what? You didn't get better, right? You still flared, right? So if you still flared, was that medication helping you? And the answer, of course, is no, it wasn't. that bladder treatments never work for me. Bladder treatments don't work for the great majority of patients out there. I did DMSO. I did urgent PC. I did antidepressants. I did bladder antispasmodics. None of them worked. Why? Well, I had a normal bladder. Isn't that weird? Now you have all these urinary symptoms. You're up all night long peeing. You're crying because it hurts so bad. Surely you have an infection. They don't find infection. They look in your bladder. You have a normal bladder wall. I had a normal bladder wall. And again, thousands of dollars on bladder therapy didn't do a damn thing for me. And then the research came out about the pelvic floor in the late 2000s. And I went and had my pelvic floor checked. And guess what? My pelvic floor was so hard, it was like concrete. And it all goes back for me to an old injury, an old pelvic injury that damaged muscles. And with physical therapy, guess what? Things got better. I have not seen a urologist, knock on wood. How long? 25 years. Now, they don't scare me at all. If a doctor wanted to look at my bladder right now, sure, I got no problem with that. Cystoscopies are important. I also believe that we deserve more than a guess. We need facts. We need facts. You need facts. So I was working with a patient on Friday who had IC for 20 years and nobody had ever looked in her bladder. And she was really suffering with a lot of pain. It's like, what are you waiting for? Well, I'm afraid of it. I'm afraid this is going to hurt me. And I went, okay, why? And of course, she'd been online. She'd been reading things online from other people talking about it. And I said, you do realize that there's a cystoscopy. I call it a looky-loo, where they can just look in your bladder, 5-minute test. It's a quick and easy way to find weird things like bladder stones. So cystoscopies are great. Or they can do a hydrodistension with cystoscopy. And a hydrodistension with cystoscopy is absolutely much more invasive. But even so, the ones they do today are not the ones they did 30 years ago that hurt so bad. Today, our national guidelines say that if you're going to do a hydrodistension with cystoscopy to get a close look at the bladder, it needs to be low pressure, short duration, so that we don't traumatize the bladder. So we don't traumatize patients who then come online and tell patients don't do that because it's going to hurt badly. Our national guidelines, hi, Lisa. Oh, Lisa asked a good question. What is the difference between a urologist and a urogynecologist? A urogynecologist has two specialties. They have a specialty in gynecology, women's care, and a specialty in urology. So they did extra coursework, a couple of extra years to get the two certifications, whereas a urologist just does a urinary tract. So that's the difference. And urogynecologists are, for a woman, are, I think, a really, if you're lucky enough to have one near you, would be a great resource. Now, here's another thing, of course, the Halloween just happened, and I have a whole scary story to share about Halloween. I forgot what I was going to say there because I got so many thoughts going through my brain right now. Here, hold on a second. Let me see if I can. It'll come to me. It'll come to me literally in a minute or two. Okay, it hadn't come to me yet. Okay, so I am here as long as you have questions. We do 5-hour meetings and we do 1-hour meetings, 90-minute meetings. Our average is 2.5, 3 hours. As long as you have questions, I am here to answer that question. When you're done, I'm done. We're all going to go out and enjoy our Sunday. Now, what we're going to talk today about when diets conflict, but I do want to share my little mini Halloween horror story. Okay, so I got to go to the House of Horrors the day before Halloween, the Social Security office. Oh my God. I had an appointment at 10:40 to sign up for Medicare Part A because, hello, I am 65 and I have to. My last day I could do it was the 31st. I got an appointment for the 30th, 10:40. I even had a letter from them confirming that I had an appointment and asking me to bring my birth certificate because guess what? They had my birth date wrong. They had my mother's maiden name shortened by a couple of letters. They had my city where I was born a couple of letters, and they didn't even know I was a US citizen. And I worked for Social Security for a year after college. I was a black lung specialist for a year. It's like, I worked for you. How could you have all these mistakes? This is crazy. Okay, so anyway, I've got all my documents in a row. I'm thinking, you know what? Jill, you're going to be in and out in 15 minutes. Piece of cake. Yeah, 3 hours later. So I get there. I check in. And the first, they finally call me my number 45 minutes later and said, well, ma'am, you had a phone appointment. And I went, no, I didn't. Here's my letter proving it. Your letter that you sent me asked me to bring things to this appointment. She goes, oh, yeah, well, you definitely got here in the right time. So, but we don't have anybody to see you. I'm like, of course, government shutdown doesn't help. And she said, just hold on. I'm going to go talk to somebody. You're here. You have an appointment. And let's see if they can see you. Okay. Yeah. 2.5 hours later, I sat there in the equivalent to the DMV, fuming, shaking with hunger because I hadn't eaten anything yet. And I'm making small talk with the guards and I'm making small talk with this and that. And I'm going up saying, guys, come on, I have an appointment at 10:40. Here's my letter. Why haven't you seen me yet? Okay. We got to do better. So for anybody out there who's had weird social security experiments, can I just say, I hear you. I had no idea it was as bad as it is now. And I was absolutely horrified. And I was so upset I made myself sick for the rest of the day. Anyway, okay. So here, hold on one sec. Let's take some questions here. And then we're going to talk about diet for a moment. Anne says, vaginal burning inside with urinary frequency and no infection. What is that? That's estrogen atrophy or bacterial vaginosis, most likely. You had a positive dip for leukocytes, but not for nitrites. Is that infection? The answer is no. That is very common for IC patients to have leukocytes in their urine when they flare. And usually that's a diet-induced flare or chemical-induced flare. And let me explain why. So the way, let's see, how do I want to say this? If you have a structural injury to the bladder wall, so let's say you're going through chemotherapy or you use some ketamine or, you just went on a bender with Diet Coke and now your bladder's super, super, super irritated. We have an erosion of the bladder wall. So now urine is getting into the tissue of the bladder wall. So it's like having a wound. Urine is going now inside of the wound, into the bladder wall itself, where it's touching cells, it's touching nerves, and doing bad things. Now, the bladder wall and skin is not passive at all. Skin is active. These tissues are very active. When there's a threat, when there's an injury, the skin, these cells send messages to your immune system. Help, 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 invasion, invasion, invasion. Something's here. It's hurting us. And your immune system then says, okay, we're going to help. So it sends your fighters, it sends your white blood cells, your leukocytes to the area to find the invader and kill the invader. Okay. So the white blood cells basically swim to the bladder wall through your bloodstream. So now they're in the capillaries. They're kind of staged in the capillaries that are in the skin. But the question is how do they get out of the capillary and into the cells to find the bacteria, to kill the bacteria? And the answer is that the capillaries open and the capillaries release the red blood cells and the white blood cells. And then the white blood cells start swimming through all the tissue. I can show you a video of it, and it's just looking for any threat so we can kill the threats. So your immune system and the health of your immune system is really, really, really important here in defeating, especially quickly, infections. Now, of course, this is not an infection. This is just a chemical injury to the bladder wall. So now you've got the equivalent of street cleaners, just swimming through the area looking for anything. But when the cells open, it releases white blood cells into urine also. It releases red blood cells into urine. And that's why a bladder wall flare can trigger positive leukocytes. And that's also why many IC patients have microscopic blood in their urine. We're really not worried about the microscopic blood. If, for example, you had visible blood, if you're peeing red, like I was working with a patient like 2 weeks ago, literally every time she peed, her toilet was filled with blood. And it's like, girl, that's not normal. And she was having trouble getting the doctors to believe her. And I said, you need to take a picture of this. Keep taking pictures, especially if you see blood clots, and email them to your doctor and say, help, help, I got blood in my urine, because that is an emergency. And if you ever cannot pee at all, let's say you've had blood in your urine, and then one day or at one moment, you have a lot of bladder pain. You really feel like you need to urinate, but you can't. And that goes on for several hours. That is a trip to the emergency room, because you could have blood clots blocking the flow of urine. That's very common. So, but that's rare in the typical IC patients. Most IC patients do not pee blood. The only ones who pee blood really are going to be a patient with either a very, very severe bladder infection that you've missed, or patients with Hunner's lesions, or patients with viral infections. Sometimes bleeding can happen from kidneys too, and sometimes bleeding can happen from cancer. So if you ever have visible blood in your urine, that, take a picture of it, email your doctor. They need to check it out. Aaron said, just had a hydrodistension with cystoscopy, ended up with an acute UTI afterwards. Very common, very, very common to get a bladder infection after a hydrodistension with cystoscopy. It's very common to get an infection anytime they put an instrument through your urethra and into your bladder, because they are pushing bacteria up there, potentially. You have terrible retention. You're on Bactrim, pyridium, and vaginal Valium. Anything else you can suggest? Help and thank you. Aaron, when did you have the hydrodistension? Was it this week? I would be drinking plenty of water. Try to flush as much as you can. I would be tracking your symptoms. Give it 2 or 3 days. And if you're not better or you're getting worse, you need to go back. They need to check it again, because it's also very common to get drug-resistant infections at healthcare facilities. So don't sit with us. If your symptoms are not getting better after a day or two, you need to let the doctor know. They need to do another urine test. They need to do antibiotic sensitivity testing. And we just have to make sure we know what we're treating here. And so be aggressive, be assertive, be vocal. Don't hesitate to call and ask for help. In the future, just understand that there are some women who struggle with, and men who struggle with recurring bladder infections. If you've had 2 in 6 months, 3 in a year, that is potentially a sign that you have a drug-resistant infection, or For women, estrogen atrophy, or maybe a challenging immune system. Maybe you're a little bit deficient in IgGs, immunoglobulin G. So that's something we want to look at too for women who get recurring infections. Kayleen, currently in the hospital, going home soon. Kayleen, I hope that they were able to figure some of this out for you, my dear. Hello, Gay. Nice to see you. Catherine says, thank you for your article in the Winter 2012 IC Optimist about ligament laxity. Girl, no, really? They did the speculum test. It took your sense of urgency right away and completely. Other issues point to the strong possibility that you have that diagnosis. Can you point me to any more info about it and ideas for how I would seek treatment? What kind of practitioner would I work with? Okay, so guys, let me see. Do I have? Let me see if I can. Okay, I'm not sure. I'm not sure which this magazine. Hold on a second. Let me look. So you have to remember that IC is a pelvic pain condition, right? It is a pelvic pain condition for which there are many potential causes. Oh, look at that. Oh, this is an old one. Oh, I missed this in my shelf. That's from spring of 2024. That's our magazine. And for anybody, this is our latest magazine, our summer fall IC Optimist, and I'm already working on the winter one. Okay. So IC is a pelvic pain condition for which there are many potential causes. You follow me so far? So for some patients, yes, it's a problem with the bladder. For many other patients, it's a problem with muscles and nerves. We now know that 85% of IC patients have tight dysfunctional pelvic floor muscles. And we also know that pelvic floor physical therapy outperforms bladder therapies 2 to 1. I mean, that's how much has changed. We don't even think of IC as a bladder disease. We think of it as a neuromuscular disorder in most patients, not all. Some patients do have bladder disease. For a lot of us, it's muscle and nerve. So, we had a fascinating case study of an IC patient that was published 4 or 5 years ago. She had the most severe IC you could have, which is Hunner's lesions, and she had a lot of Hunner's lesions. She also had a very bad prolapse. The muscles were very weak. Things had fallen. Her bladder had fallen out of position, or her vagina had fallen onto her bladder. I'm not sure which. I don't remember. But anyway, it was so severe, the doctors decided that they needed to do surgery. And they made a remarkable discovery when they opened her up, that her uterus was backwards. So the front of her uterus was facing the rear, and the rear of her uterus was facing to the front. Why? Because a ligament was broken, and her uterus was free swinging like this. We call this posterior fornix syndrome, and it happens when a ligament is broken, or in some cases, a ligament can just be stretched out of position. So obviously, they had to fix it. So they kind of untwisted her uterus. They tacked everything back into the right place and opened her up. Or closed her up. And guess what? Her Hunner's lesions disappeared completely. So this is called posterior fornix syndrome. So why would that occur? Well, we have 2 theories about what causes a Hunner's lesion. Theory number 1 is that it's a viral infection. And we have patients who do have viruses causing lesions. There's no doubt about that. Our own National Institutes of Health IC team found virus in about 5% of patients. And if you got my email, I sent out an email like 2 weeks ago. It was an interview with 3 urogynecologists. They talked about how they believe that a lot of children are getting viral bladder infections. They just kind of naturally go away. Okay, so theory number one, viral infection. Theory number two about a lesion is that it is a nerve that is very, very, very inflamed, and that nerve is releasing bad things called substance P, which damages tissue and causes lesions. So that is what we think's happening with this ligament, because it turns out, so here, let's see. Okay, let's just say this is your bladder. So your bladder has nerves that go up to the spinal cord. Okay, so your bladder has to have a way of communicating with your central nervous system. So here's your bladder, and here's a nerve that's coming out and going up to your spinal cord. Let's say you have a nerve on this side and a nerve on this side. So this nerve, as it's coming out of the bladder, sits on something. There's something that holds this nerve in place. It's the ligament. It's the uterosacral ligament. So the uterosacral ligament isn't just holding the uterus in place. It's a platform that holds bladder nerves in place as they're coming out of the bladder. So when this ligament is stretched out or broken, the nerves go like this. The nerves get stretched and they become very, very inflamed. And what's interesting is this message. Now we've got the bladder nerve inflamed. It's not the bladder, it's the nerve outside of the bladder. But that nerve is going, help me, help me, help me. It's sending messages to the brain. And the brain goes, oh, you must have a bladder problem. And it makes you pee a lot. And it gives you urinary symptoms and urgency frequency. This is called posterior fornix syndrome. So it's so interesting here. And you have to understand, Western medicine fails the typical pelvic pain patient because doctors only play in their sandbox. Urologists only look at the urinary tract. Gynecologists tend to look at the reproductive tract. They don't necessarily look outside of it at muscles and nerves. So in 1991, when they discovered posterior fornix syndrome, and you go back and you look at those articles, they all talk about all these bladder symptoms that happen when this ligament gets stretched out. But of course, the urologists are like, we don't want to look at we don't want to look at ligaments. Even gynecologists, they don't necessarily look at ligaments. And now this movement is growing. We're playing a big role in that because I'm talking about this a lot now. And now the experts in this ligament issue are proposing posterior fornix syndrome as a phenotype for IC. And I agree with that. Every IC patient should be tested for ligament laxity. It's simple. It's like literally a wooden speculum that they put up by your cervix and just lift. And if they can lift and stop the pain, then we know we're dealing with a damaged ligament. Therapeutically, Catherine said, who would treat it? Your gynecologist would treat it. I mean, if you've got a stretched out ligament, then I don't know if physical therapy would help or not. It might be a referral to a physical therapist. But in some cases, especially if that ligament is broken, it's a surgical intervention by a gynecologist. So you would be working with a gynecologist or a urogynecologist. And said, urogynecologist had me stop topical estrogen used for a month, thought I was burning from it, but it was a yeast infection. So can this burning and frequency be a bladder wall flare? It could be a bladder wall flare from estrogen atrophy and dryness. It could be a urethral flare from estrogen atrophy. It could be a vaginal flare from estrogen atrophy. Hey, Wendy. Kayleen said, I have to go back to physical therapy for my back. I see a urologist on Tuesday, a urogynecologist on Wednesday. I'm more interested in my urogynecology appointment because she's having a genital pain no matter what body position she's in. So she's sitting, she's standing, she's bending over, she's trying to sleep, she's having pain in all of those positions, which definitely points to an issue potentially with a nerve. She had an MRI, though, that said her L5S1 has gotten a little bit better. Okay, well, you're healing, girl. You're healing. Your case is very, very complex. There are a lot of multiple things going on there, but I think working with a neurologist is the right thing to do. Laura said, I have been having physical therapy for levator ani for weeks now. I lifted a mattress, feel pressure again, but not as bad as it was. Therapy is working. I have been walking an hour a day. You go, girl. I only have small bowel movements and have to wipe about 7 times. Will this ever get better? Even with improvements with physical therapy, I still don't empty my bowels all the way. I would love to see improvements on this. Thank you. Well, that kind of ties into what we're going to talk about today. Hello, Johanna. Nice to see you, hun. Just so you know, guys, we're streaming on 2 platforms, not 3. We're just streaming on Facebook and YouTube today. So normally when I do these meetings, I do a little educational thing first, and then I take your questions. And so I have been talking about this brand new diet book we're doing. Got the here. This is how thick the new diet book is. I just did my 2nd round of edits. Now I'm going to send it off to Bev Lauman for her to look at it. Okay. So one of the things that I have in this book that we've really never talked about in any of the IC resources out here is, what do we do when our diets conflict? Now the IC diet is hard enough. If you've got a very sensitive bladder, God forbid you have Hunner's lesions, just, eating or drinking the wrong thing could lead to hours of pain. And there are many patients out there who become afraid to eat. It's really, really confusing, because one day you can eat something and the next day you try to eat that same thing again and it flares you. And so the purpose of our book is to give you a pathway through that. Because I don't want you to be afraid to eat. The IC diet is actually a very simple, easy diet to do, unless you have other conditions. If you've got other conditions, for example, let's say irritable bowel. So I'm an IBS patient. I had IBS before I ever had IC. And so in the IC diet, we're going to avoid strong acids and caffeine. And things like chocolate and coffee and soda, lemon, lime, citrus, tomato. Those are the things that are going to be the most well-known for triggering an IC flare. Things like steak sauce, spicy sauces, things like that. One of the things that we gravitate to is carbs. Bread, because bread's IC friendly, right? Most of the time bread is IC friendly. And so for many patients with IC, myself included, I went through a period of time where I kind of lived on Bisquick or Jiffy Mix muffins and sliced turkey. I mean, really, I'm not lying, because I knew I could eat that and I wouldn't have an issue. But then I got really, really constipated, really badly constipated, because I didn't have any fiber. So for the IBS diet, the dietary recommendations for that is to bring down insoluble fiber and bring up soluble fiber. And that was something I learned early on. I was having these really painful bowel movements. And I thought, and everybody kept saying, eat oatmeal. Well, I'm sorry, I would eat oatmeal and it would be worse. I would eat granola and I'd have substantial poops, but they were painful. It was painful. It was uncomfortable. And Heather Von Voris, the author of First Year IBS, appeared in one of our live IC events. And she explained that when you have irritable bowel syndrome, you've got very, very sensitive nerves in your bowels. And they are very, very easy to trigger. And starting a meal with a strong, irritating fiber is going to trigger potentially diarrhea or constipation after the meal, which I had many, many times in my 20s when I was struggling with IBS. I don't know what it was about eating a salad, but we would go out and have a salad, and an hour later, I'd be in the bathroom, and I was very, very frustrated. Because salad, leafy greens are actually insoluble fiber. They actually have sharp edges that irritate the bowel. And so as she explained, if you can have salad, just have it at the end of the meal. Don't have it at the beginning of the meal, have it at the end of the meal. And if you're looking for fiber, you got to get your normal 20 to 25 grams of fiber a day. Don't look at insoluble fibers like granola. Look at easy, soft, gentle fibers like green peas. And so the biggest, the IC and the IBS diet are virtually identical, which means simple, fresh, healthy food, lose the junk food, lose the caffeine, but just emphasize soluble fibers rather than insoluble, irritating fibers. Okay. Now, what about food allergies and food sensitivities? It's very, very common for a patient who has a reaction to a medication or a food to say, I have an allergy to that. But most of the time, it's not a real allergy. An allergy, there's an allergen that's triggered a very specific histamine response in your body. You can get a rash, your throat could swell. Patients who are allergic to peanuts, for example, can die if they're exposed to peanuts because that true allergic reaction affects their ability to breathe. But that's not as common as what we call a food sensitivity. A food sensitivity is just basically, an easiest way to think about it is that your body just doesn't know how to digest that food. Your body interprets that food kind of like poison. So for me, my body interprets oatmeal as poison. Now, I'm not allergic to it, but God forbid I eat it. Wherever that oatmeal is from my stomach down, cramps like a beast, and it hurts bad. Now, of course, I come from Norway and Sweden. My ancestors never had oatmeal. They didn't grow oatmeal in northern Norway or Sweden. Although they ate fish. That was pretty much it. And so I argue that my body just doesn't know how to process oatmeal because my ancestors weren't exposed to substantial amounts. So there are food sensitivities that we all will have. It's impossible to predict these sensitivities. You have to listen to your body, and it's always really good to do a food diary and track your symptoms on any given day along with what you eat. And that will help you tie the two together. So I can remember, Diane says, my gut can't handle oatmeal either. And you're Norwegian and see? We're not crazy. Literally the food everybody says you should eat, it's like poison. I can't touch it with a 10-foot pole. And the irony is I can remember making oatmeal cookies as a kid and getting sick from it. Okay, so I had a 50-year-old call me who was furious at me for publishing the IC diet because her mother, who was in her 80s, had been diagnosed with IC, and she printed out the IC diet from our website, and she had her mom stop all of these foods, and she said her mom flared on everything. And she said, clearly your data is wrong. This did not work for my mom. Most of those bladder-friendly foods really, really bothered her. And then she said, we went to a doctor and we had some food testing done. And it turned out that her mother was sensitive to wheat. Her mother was sensitive to a whole bunch of foods that were on the bladder-friendly list. And of course, there's no way we can predict that. So usually as we get older, we all learn that there are some foods that we're sensitive to that we're just not going to react to well. So just differentiate in your mind between that. Now, what about celiac? Now, there are absolutely a small population of IC patients who definitely have celiac disease. They cannot process gluten at all. If they have gluten, they're going to have bowel symptoms and potentially bladder symptoms. Celiac disease can cause a bladder reaction to gluten as well. And so for these patients, they go on a gluten-free diet, and that tends to improve dramatically. What's so interesting is a lot of us, even though like I got tested for celiac, I was celiac negative, but I'm telling you right now, I do way better gluten-free than I do with normal wheat flour. I do. So if I make pancakes, I use a gluten-free pancake mix. I know I learned back in my 20s that if I started the day with cereal like Cheerios, I would be bloated and gassy and irritated all day and nauseous. Once I stopped the cereal and I stopped the gluten, and I actually went gluten-free and I went vegetarian for like 5 years just to try to figure out this whole thing going on with my stomach. Gluten-free definitely works better for me. If I eat a lot, the only wheat I eat is going to be a panini roll or a sourdough roll. It is what it is. Okay. Let's see here. So let's talk about vulvodynia now. So if you've got IC and for women, vulvodynia. It was, so vulvodynia means that you feel like you have a yeast infection all the time. You might not be able to wear underwear. Your crotch basically feels like it's on fire. When I had vulvodynia, it felt like I had, so somebody scrubbed all the skin off on my vulva with sandpaper. Vulvodynia is nothing to be laughed at. It can be agonizing. Now, the cause of vulvodynia is generally neuromuscular in origin. The nerves are being compromised by very, very tight muscles, but we can deal with estrogen atrophy. There can be other things going on too. Chronic yeast certainly is a possibility too. There's no doubt about that. So here we have a very, very sensitive skin on the vulva. Lots of inflammation on the vulva. Why would a vulvodynia patient be dietary sensitive? Well, it was actually Dr. Clive Solomons, God rest his soul, he passed a few years ago, who discovered that foods high in oxalates irritate the vulva in urine. So if you eat, let's say you eat a lot of berries or you eat a lot of chocolate, oxalates are chemical crystals that will end up in your urine, and literally as you're peeing them out, they cross your vulva where they scratch your vulva microscopically. And so some vulvodynia patients have to eliminate foods that are high in oxalates, like beets, spinach, Swiss chard, parsley, kale, okra, collard greens, nuts, nut butter. Oh, like almond butter, almonds, almond milk, very high in oxalates. Wheat germ, tahini, tofu, and green and black tea. Those are the things that are going to be particularly high in oxalates. And so as an example, my mother had lichen sclerosis and very severe vulvodynia the last 20 years of her life. She followed the Clive Solomons protocol of eliminating the oxalates, and it absolutely helped her. No doubt about it. For me, I mean, thankfully, my severe vulvodynia days are long, long gone, but I could eat anything and it never touched my vulva. So anyway, that's one thing to think about if you struggle with vulvodynia, playing with reducing some of the high oxalates foods. All right, now let's talk about stomach issues. So this is so interesting. Growing up, had, especially in my 20s, when, you know, the chronic overlapping pain conditions kicked in, had fairly horrific stomach issues at times. I can remember I had several bouts of gastritis, usually in the summer, where my stomach was in so much pain, I could barely eat, and my stomach was very, very, very inflamed. And then later, I was diagnosed with gastroparesis, which is delayed stomach emptying. What's interesting, though, is when you actually come to an IC support group and you start meeting a lot of other patients, you realize, you know what? Many, many IC patients have similar stomach problems, whether it's GERD, whether it's, esophageal reflux, if it's gastritis, etc. And so when you go back and you look at the early IC studies, you see that they talk about IBS, but they don't ever talk about stomach symptoms. And so we did a survey. I did a survey, it must have been 10 years ago, of over 1,000 patients, IC patients. 95% had chronic stomach problems. 95. 73% struggled with abdominal bloating, 57% had gas, 55% had GERD, and 47% had persistent nausea. Most of the patients had stomach problems every single day, and 57%, 32% had it a couple of times a week. 57% diagnosed with IBS, 50% with GERD, 40% with gastritis, 21% with gastroparesis, and stomach ulcers actually turned out to be very, very rare at just 15%. So for a patient with irritable bowel, for a patient with gastritis and stomach issues, our goal is to reduce inflammation. And so the way we're going to do that is by avoiding foods that irritate the stomach, which happens to match almost perfectly the IC diet. So that means losing the caffeine, because caffeine irritates nerves, losing high-fat foods, fatty foods, fried foods, foods high in saturated fats, heavily spiced foods, alcohol, and acidic drinks and coffees. Okay, so that's easy. And instead, we're going to be eating things that are calming and soothing to the bladder, very easily digestible foods like the Brat diet, bananas, rice, applesauce, and toast. For patients who can tolerate it, you can do oats. That's not me. Rice, mashed potatoes, sweet potatoes, of course, without any butter or anything like that. Understand, too, that raw vegetables are much harder to digest than cooked vegetables. And, of course, if you struggle with farting and gas, I can still remember I was working with a patient maybe 10 years ago who had horrific farting. And she'd gone to the doctor. The doctor just didn't know what was wrong with her. And it was just every single day, stinky, painful farting. And so she called me and said, Jill, can you help me with the fact that I'm farting all the time? And I'm like, yeah, do you know the gas producing foods? And she's like, no, there's foods that cause gas. And I went, yeah, nobody's ever talked to you about that? She goes, no. And I went, okay, cabbage. Like, you can't pay me to eat cabbage. Cauliflower. For some patients, broccoli, although I can eat broccoli, no problem. But the number one offender, Brussels sprouts. You couldn't pay me to eat Brussels sprouts. I hate Brussels sprouts. I know some people like it, especially in the fall, especially when you saute it with a little bacon. Not me. And I said to her, I said, do you eat Brussels sprouts? She gasped. She goes, yes, every day. And I'm like, what? How are you eating Brussels sprouts every day? Turned out it was her snack. That on the weekend, she cooked a big pot of Brussels sprouts, seasoned it, and then put it in the refrigerator. And every day, she snacked on 4 or 5 Brussels sprouts a day. It's like, oh my God, if I were doing that, I would literally be hiding with nobody could be around me. I can't even begin to imagine, how much distress that was causing in her gut. And she's like, but I love my Brussels sprouts. I'm not giving up my Brussels sprouts. And she called me back a month later and she goes, oh, Jill, it's so bad. And I went, did you stop the Brussels sprouts? She goes, No. And I said, then why don't you try it? Lose those Brussels sprouts for a couple of weeks. And what do you think happened? Yeah, she got better. Now, for patients who have gastroparesis, and I'm one of these patients, and I work with gastroparesis fairly regularly. Gastroparesis basically means that the nerves in your stomach are slow. And so your stomach is not emptying quickly, that foods are sitting in your stomach for longer periods of time where they ferment. And you know what happens if you put, if you're making bread and you create your yeast, you season your yeast by putting it in warm water with sugar. What does it do? It starts to bubble. Well, that's what foods in the stomach do if they're not being passed. They start to bubble and ferment, and before you know it, you're belching all the time. That's what happened to me. I just all of a sudden had all this gas in my stomach. I didn't know where the hell it was coming from. It was this temporary irritation of the nerves that stopped them from moving as quickly as they should have. And so for patients with gastroparesis, it's all about eating foods that are very easy to digest and avoiding those foods that are harder to digest, like salads, like granola, small, easy meals throughout the day. And I will tell you, gastroparesis was, you can go back and look at the videos. I think it happened, I was at the gym when it happened the first time, like in October or September, something like that. And all of a sudden I just felt this pressure. By November 10th, I couldn't even drink water. And I think I'd lost 20 pounds. And I ended up at the emergency room and they admitted me overnight because my heart was racing. And I was massively dehydrated. And it was just this stupid gastroparesis. So the treatment for that was very, very small, easy to digest meals. And I actually closed the IC Network office. I used to work down in a big office and moved it home so that I could eat these little meals. All right. So anyway, we do talk about that in the book. Now let's talk about migraines for a moment, because a lot of IC patients have migraines. Migraines obviously are very, very, very intense headaches. You often know that a migraine is going to happen. There are some early warning signs. I had migraines just for a brief period of time in my 20s. There is this perception that foods drive migraines, a food like chocolate. So the biggest risk factors for migraines are genetics, blood flow issues, stress, and hormone fluctuations. Those are the dominant causes of migraines. Stress and hormone changes, especially if my cousin had terrible migraines when she was younger, when she went through puberty. And it was all just completely driven by hormone issues. So some patients learn that there are foods that trigger their migraines, like chocolate. And so if you've got IC and migraines, you're going to have to avoid those foods. I will tell you, though, that research has not supported that other than caffeine. We know that if you're having a certain amount of caffeine every day, that is absolutely linked to chronic headaches. The American Migraine Foundation says only 1 caffeinated cup of coffee a day. But if you have IC, you shouldn't be drinking caffeine anyway. Okay, TMJ. For those of us who have TMJ, there is a dietary modification, but it's not the food you're eating as much as it is the hardness of the food you're eating. So if you struggle with TMJ and IC, you just have to avoid the hard, chewy things. That easy. Hard, crusty sourdough bread, hard, chewy caramels, things like that. It's all about protecting that joint. And then we've got our lupus patients, our Sjogren's patients. So if you have lupus or Sjogren's, then you need to do the autoimmune diet. And that means you're going to lose the sugary foods, the refined carbs, nightshades, like bell peppers, eggplants, potatoes, and alfalfa sprouts. Okay. And then last but not least, we've got some patients who have chronic yeast infections, chronic fungal infections in your bladder. You don't just have fungal infections in your vagina, you got fungal infections in your urinary tract. If you flare when you eat sugar, if you flare when you eat carbs, the odds are you've got some candida growing in your bladder. Strange. I mean, when you think yeast infection for women, you're thinking vagina. It was our own IC research team at the National Institutes of Health, the MAP Research Network, that actually found candida infections in the urine of IC patients. And what they found is the more candida you had, the more bladder pain you had, by far. So the question then is, why are IC patients prone to fungal infections? Because we're probably the most overexposed group of patients to antibiotic. That when you take an antibiotic, you kill the bacteria that keeps fungal infections in check. So now we have this growing body of data that continues to find significant fungal infection. I mean, you think you have a bladder infection, you have all the symptoms of a bladder infection. They do a bacterial test, they find nothing. The doctor goes, sorry, we don't find anything. And yet you really could have an infection. It could be a fungal infection. And that's why the next generation DNA urine tests are so meaningful, because that will rule out a fungal infection. And again, this is not this crazy woman online saying you all have fungal infections. This is the National Institutes of Health saying we found it. We found it. When we look at the urine of IC patients over time, we find consistent fungal infections in some IC patients. So I want you to be attentive to the fact that if you flare after eating sugar, if you flare after eating carbs, and you've been on antibiotics, and God forbid you be self-medicating with leftover antibiotics every time you flare, you are creating the perfect storm where fungal infections can grow in your urinary tract. And so for these patients, how do we treat that? Well, sometimes you have to do intensive aggressive courses of antifungal meds. That's what I had to do. You know, it's not taking one diflucan, it's taking a lot of diflucan for a long period of time to the point that you're dealing with liver toxicity issues. So some of these fungal infections are very, very drug resistant. So, but most of all, it's about reducing all the sugar. Sugar feeds fungus. And I learned very quickly that whenever I ate ice cream, my candida grew, so I cut out the ice cream. And now that I'm a cancer patient, I'm looking at all that data that shows that cancer cells grow with sugar. I threw out my Halloween candy. I mean, I ate 2 Twizzlers. 2 Twizzlers. That was it. It's all gone. You know, life is precarious, and especially as we get older. And it is our responsibility to feed our body good, nutritious, healthy food. That is very, very hard in today's environment where we're dealing with a lot of junk food, preservative food, fast food, high fatty food, high sugar food, all created by companies that are trying to sell you something and they want you addicted and they don't care if they hurt you. You know, it is our job to say, I'm not going to be your victim anymore. I am not going to come by your hamburgers. I do not know where the heck your meat came from in the first place. And I know eating salty fries, fatty fries, in the long run is not going to be healthy for me. So having a diagnosis of IC is often a wake-up call. It is a wake-up call that forces you to confront some pretty significant dietary habits and fixing them. And that means making food. Not going and buying food. Like, make it where you have total control over your diet. I went to the farmer's market yesterday. I bought butternuts. I'm going to make butternut squash soup for dinner tonight. I bought zucchini. What else did I buy? I bought a lot. I bought portobello mushrooms. Anyway, the farmer's market is my friend, and I love going there and just getting real food. And also trying not to eat a lot. They basically recommend that you eat 5 small meals a day. That's very hard for me because I basically only eat 2 meals a day. I have a smallish breakfast, which is usually toast and an egg. And then during the day, I will snack on, what will I snack on? Oh, that's a good question. Sometimes avocado, tortilla chips and avocado, or popcorn, air pop popcorn, or microwave popcorn, but with no butter. I tend to eat a lot at dinner, and I tend to eat too much, and then my stomach hurts. So it's something I want to try to fix too. All right. So anyway, our new book, the IC 101 Diet Guide, we're going to have a lot more information on that on these, so that if you are navigating multiple conditions, to kind of give you a roadmap on how through that. But just understand the common thread in all of this is just cleaning up your diet. That's massively cleaning up your diet, losing the fats, losing the sugar, all that sort of stuff. And just coming back to the food that our grandparents ate, making a meal. You can have any meat you want. Go buy meat. It's okay. You want to grill up a steak? It's fine. Just don't put the steak sauce on it. That's going to hurt. Don't do those hot, spicy rubs. Their odds are the spice is going to be potentially irritating your bladder, and it's probably going to have an MSG in it, which is also going to irritate your bladder. Vegetable aisle is your friend. You can eat a ton of veggies. The veggies are not going to irritate your bladder. The only one you got to be really careful of is tomato. But it's about the quantity of acid. I can promise you, most of you can probably have a slice of tomato on a sandwich, because there's very, very little acid in a single slice of tomato. It's the acid of a dozen tomatoes that have been cooked to make a cup of tomato sauce. That's where you're in a flare. That's where you're in a flare. So it's also about the quantity of acid. So there are some patients out there who they read everything, and if they see a little tiny bit of citric acid as the last ingredient, they don't buy it. Don't do that, because anything that is sold in that way has to have a preservative. Well, it's kind of an acid stabilizer to prevent the food from breaking down. Odds are it's going to have a little tiny bit of acid in it, but the odds are it's probably not going to bother you unless it's a first or second or third ingredient. Then there's a lot in there. So don't be afraid of eating. You don't have to be afraid of eating. You just got to eat better. And the holidays are coming up, and it's fall. And you know what? Listen, the fall foods are perfect. Can you have turkey? Yes. Can you have sweet potatoes, mashed potatoes, all that sort of stuff? Those are generally IC friendly, unless you've got to avoid the sweet potatoes because of oxalates. The fall soups, chicken noodle soup, butternut squash soup, pumpkin soup, beef and vegetable soup. Those are going to be fine. So this is the good time of year. Nancy says, was feeling good for years, and I started a new workout class, higher impact. Now I have a terrible flare. I can't seem to break. So defeated. Any advice? I did stop the workout. Yeah, girl, you had a pelvic floor flare. That's and these really kicked in during COVID. Because here everybody was stuck at home for COVID for a good year, right? If you were lucky, you went and walked. If maybe you had yoga that you could do over the computer, things like that. But when people started going back to the gym, they were making up for lost time. And so people dove into their workouts and started also lifting very, very heavy weights. And we have worked with so many patients. I have worked with so many patients who have been hurt in the gym, especially in the last 2 years. And so if I were you, I would go have a pelvic floor assessment, and let's check your muscles to see what's going on with your muscles. And I want you to be really attentive to where the pain is. Is it on the left side? Is it on the right side? Is it shallow? Is it deep? Is your pain positional in nature? Are you fine when you stand, but when you sit down, it hurts, or when you bend over, it hurts? Those are all very clear symptoms of muscle issues. Also, do you hesitate to urinate? Can you pee like a horse, like sit on the toilet and let it fly? Good volume, or are you stopping and starting? Or are you hesitating? Or are you having to to strain to release urine. Those are all signs that we're dealing with a pelvic floor that's kind of messed up. So I think your next step is to have a proper pelvic floor assessment. All right, let's come back here to Facebook. Anne said, all my issues started when I started topical estrogen. You ended up with a bladder and yeast infection. You have shingles on your face. Is this interrelated? Is there a hormone-driven phenotype? Absolutely. I mean, from day one, running a support group, I encountered patients who flared when their estrogen was high, and there were other patients who flared when their estrogen was low. And I have argued for this phenotype. I think it's a small phenotype with a number of doctors. Nobody's ever studied it extensively. What I can just say is that once these patients had their hormone levels stable, whether it was from birth control or whatever, or in some cases Lupron use, their symptoms mellowed out. So the very first thing that it makes me think of is, are we dealing with weird hormone fluctuations? The second thing is the quality of the topical estrogen that you use. If you were using Premarin, if you were using a mass market Premarin cream, these mass market creams have a lot of preservatives in them, which can be very, very irritating. So it's not at all unusual for some patients to flare when they start using an estrogen cream, not from the estrogen, but from the preservatives that are in the estrogen. And this is why many doctors instead send you to a compounding pharmacy where they will use a preservative-free formula. My estrogen is propylene glycol free, and that was something that my gynecologist ordered for me. So I would have to wonder, are you having a reaction to the estrogen cream base? I don't know why estrogen cream, it would not cause a bladder infection, honey, because a bladder infection is an infection. There's a pathogen in there. There's a bacteria in there, or a virus or a fungus in there. If anything, the estrogen would help your body fight off those infections. So the only time we're going to see that is with kind of a community exposure where you can get bladder infections from food, you can get bladder infections from meat, you can get bladder infections from not washing your hands, you can get bladder infections in lots of random ways. I just don't see how an antifungal is going to give you a bacterial infection unless it was contaminated in some way. But again, if it was a mass market cream, the odds are it had preservatives in it that would have prevented that. So that's when you call the pharmacy, if it's a compounding pharmacy, and you say, hey, you know what? I used your product and I got an infection. Have you encountered any other issues like that? Is there a manufacturing issue? Now, the shingles and IC are not related at all. Shingles, I'm so sorry you're going through shingles. That's brutal. Shingles comes from the measles or the chickenpox virus that almost all of us have had, living in our body, and then in periods of very, very intense stress and trauma, that virus turns on and causes shingles. And shingles follows very, very specific patterns along nerve pathways. So oftentimes it's on the chest. My brother had a shingles vaccine and 2 weeks later had an attack of shingles on his chest. Hasn't happened to me yet, knock on wood. At least I don't think it has happened to me. I would strongly encourage you to consider PEA, Peora, because we have research showing that the nerve calming effect of PEA has been helpful for shingles. Joanne says, what causes lichen sclerosis? So lichen sclerosis is like very, very severe inflammation or neuroinflammation on the vulva. So what happens, what's so interesting here is that when you look at the vulva loses its redness. It gets very pale, which implies that we're also potentially dealing with some compromised blood supply. So you know how if you push on your skin, if you push on it, it would turn white, and then over a couple of seconds, the color would come back. That's not a good example because oh, look at that. I was gardening today. Normally you would see an area of whiteness, and then there you go. And then it takes a couple of seconds for the blood flow to come in. There is a suggestion that very, very tight muscles are causing ischemia or ischemia, which is restricting blood supply to the vulva. And that potentially could explain why the vulva seems to start losing its blood supply. But lichen sclerosis can also absolutely be related to just very, very severe estrogen atrophy, as well as a lot of chemical irritation. If you're using something, some of these bathroom wipes, big mass market brands, I don't want to say the name because I don't want to get sued, but if you go to the store and you start buying these perfumed wipes or these wipes for cleanliness down there, odds are they also have propylene glycol in them or something like that, which is going to irritate the skin. That actually happened to my brother-in-law. He started struggling with a lot of skin sensitivity from a wipe that they were using. And so look at wipes, look at any chemical irritants down there too. But I would definitely want to have a pelvic floor assessment if you have lichen sclerosis. Just out of curiosity, let's just make sure the muscles aren't playing a role here. Kayleen says, for crying out loud, I barely eat, and the only chair I'm comfortable in is my recliner. It feels like hitting a brick wall in my vagina. Tight pelvic floor muscles, fibroid tumors, endometriosis, pelvic congestion syndrome, all need to be ruled out. Carolyn says, I've just been diagnosed with lichen sclerosis. It's awful. Girl, yeah, lichen sclerosis is a bitch. Excuse my language. It can be brutal. You might find that you do not do well with underwear. So my mom, honestly, she didn't wear underwear anywhere. If we had to go out, she put on very loose pants. She was 94. She had her supply of Corette elastic waist pants, preferably dark blue. and she just, and her underwear, she bought, okay, she was very petite. She bought size 10 underwear. It's cotton underwear with cotton bands around the arms. You could only get them at the Vermont Country Store. And so she had these giant granny panties on for those moments when she had to wear underwear that just hung, so nothing was touching her vulva. I mean, she really suffered. I was her caregiver. I always was very discreet. I didn't want to take any of her privacy away. So when she had to have bathroom moments, it's just I walked her to the bathroom and then I walked out and shut the door. We didn't figure it out until almost the near end when finally she couldn't walk to the bathroom at night. So I had a porta potty right next to her bed, and she was somebody who loved to sit on the toilet and read for extended period of time. So again, I gave her privacy. I just shut the door. She was sitting on her porta potty reading or in the bathroom reading. And then one day I walked by and she was like okay. She was like this on the toilet, like this. and she was straining as hard as she could. Man, she was like, ah, like that. And I just stopped me in my tracks and I put my head in there. And I was like, Mom, what are you doing? What are you doing? And she's like, well, I'm trying to poop. And she was straining as hard as she possibly could, which helped me understand why I kept finding poop in front of the toilet, because she was lifting her butt off of the toilet and pushing really, really hard. And it's amazing how common that is. And that solved for me the issue of her lichen sclerosis. Her pelvic floor was toast. She had 3 kids. I was her youngest, and they were difficult childbirths, and we were big babies. I think in hindsight, she'd had pelvic floor dysfunction for decades, ever since she had me. And I think that's why in the end, she was straining so hard to have bowel movements that her muscles just got tighter and tighter. And eventually it cut off the blood supply to her vulva and caused lichen sclerosis. Lisa, thank you, Lisa, for the 100 stars. Lisa says, sending support and hugs to all my IC sisters and brothers. Thank you for all that you do for us, Jill. You're very, very welcome. I love my job. Anne says, 2 diflucan. Ouch. All right, let's come back to YouTube here. Nancy says, could it be pudendal? Well, pudendal neuralgia, patients have very positional symptoms. So, and nerve-centric symptoms. So you might feel a sharp shooting pain down your legs, sciatica. You might feel a vibration. You might feel areas of numbness or pins and needles. You might have clitoral pain, very sharp clitoral pain. You might have, we call it PGAD, persistent genital arousal disorder, where suddenly you're in the middle of your day driving in the car to work, and all of a sudden you're overcome by this very strong arousal sensation. It's just like, wait, I'm driving. I'm not even listening. There's no reason for me to be aroused right now. That's actually a muscle squeezing a nerve, the pudendal nerve that goes to your clitoris. Okay. And so if your symptoms are positional, that's definitely something that they have to look at. When you're at the gym, because Nancy, you were saying this all started with a new workout class. God forbid you were spinning. Do not get on a bicycle. The bicycle saddle directly pushes right up into the pudendal nerve and into the muscles. So there's a chance that, maybe you injured a nerve, at the gym, whether it's lifting heavy. The other thing we're seeing is, and again, this is this trend right now where you're wanting to lift really, really, really heavy weights. So I was working with a guy who his trainer put 40 more pounds on whatever he was lifting. And he said, "Oh, just try it." And the guy tried it, and he popped a hernia holding the weight. I mean, it was an emergency. He had to go to the hospital. He had emergency surgery to repair this hernia down by his groin. But that's when his IC started. And he didn't understand that he had muscles inside his pelvis that he hurt too. It wasn't just that hernia that got popped, that he suffered a very, very severe pelvic floor muscle injury from lifting that heavy weight. So we sent him off to physical therapy to get that worked on. Very, very common these days. Quite interesting. For me, I used to be a gym rat. My workouts were, for many, many years, I did 100 flights of stairs a day. My workout was I would go swim a mile or 2. And then I would get on the Stairmaster and I would do 100 flights of stairs. And then I would go row 5 miles. I did that workout every day for about 10 years, or at least 5 times a week. I was a gym rat, and I just felt at home at the gym. I was never into team sports. I was a tennis player. I was an individual player, and I just loved how I felt when I worked out. And it was just a great way to reduce stress and eliminate stress, and a great way to process stress and think about things. And I love that Stairmaster. What I didn't know is that all the damage I was doing to my pelvic floor and to my feet, because I have no fat pads on the bottom of my feet now. And the doctor just said, you just broke them up. You just worked out way, way, way too hard. And if I had known that, I really would have changed things differently. We make a lot of demands on our body that our body was not designed for. And if I could go back in time, I would be a lot more gentle than I was. And maybe look for other ways to manage stress too. It's just a great way to manage stress for me personally. Because life is hard. Anybody else like totally stressed out right now? The weird time. I was talking with somebody that I respect immensely, that I've known for over 30 years. A very famous IC person, at least famous in our world, and very conservative, very calm, very collected, she's very research oriented. And I called her up because I wanted to talk about something that I was writing. And she said, life is effing crazy right now. And she used the word. She used the F word. And I was just like, I have never heard you swear before. It's bad if she's swearing. And I said, it makes me feel good because I swear every day now too. And she goes, well, the research shows that the more educated people swear more. And it's like, okay, well, that's me, I guess. What the research does show is that when you curse, you actually, as long as you're not doing it all the time in other people, it actually changes your brain chemistry in a way and helps moderate pain. And the book that talks about that is, where is it? Nope, that's not it. Where's my book? Where is it? Oh, that's so weird. It must be over there. Anyway, I have a great book that we sell in the IC Network shop on pain management, and it talks about it there. Huh. Oh, it's somewhere. Well, my office has a lot of books in it, and I'm not reading near enough. I should be reading more, but I'm trying not to be addicted to my iPad, but I am kind of addicted to my iPad. By the way, cutest costume that I saw on Halloween night was a kindergartner wearing a K-pop demon hunter Genu costume. He was adorable, and his mom was one of the was Zoe and Huntrix, and it was just adorable. And she said, I stopped and I said, I love your costume. And her mom said, tell her who you are. And this little light little voice, he goes, I'm Genu. And I went, you're a hero. So cute. All right, we've been going for an hour and a half so far. Now, you guys, if I missed your question, feel free to ask it again. The rule in my office is be a very squeaky wheel. If you call me and I don't call you back, call again. Call over and over until you get me. things get very, very busy throughout the week. Let me take a look at, hold on a second. I know that one of the challenges that we have right now is the National Library of Medicine is not being updated during the government shutdown. So as much as I would love to tell you all the new research, I can't because the office is shut down and the library is shut down right now. But I do think that I got an email. Hold on a sec. Hold on. I just got to find it. Wow, so much email. And I got to go get my eyes checked. My eyes are just, it's been 3 years since I had my eyes checked. I think I need a new prescription. Here we go. So the research is happening in other countries right now. Now just understand that the ICU research movement is shut down. The MAP Research Network is over. This is the first time since the 1980s that we do not have dedicated ICU research funds. I will also tell you that the Army contacted me a couple of weeks ago to come back onto the CDMRP ICU research panel or to assist in the planning of the future of that program, which is very, very happy to do. CDMRP is congressionally directed medical research program. So these are monies allocated by Congress to support studies for a variety of conditions. Interstitial cystitis has been one of those conditions for many, many years now. So when I did it for about 10 years, allocated millions and millions of dollars of IC research. All that's done. We got nothing right now, other than some potential proposals. I mean, grant listings, but we don't know if anything IC is going to get funded in the next couple of years. It's a very, very dire time in the IC research movement. Very, very dire. Your vote matters. You better vote for people who believe in research. So anyway, but we do have some research coming from Asia and from other parts of the country. So here we have a new research study from, here, hold on a sec. This looks like it's from Japan and Australia. Oh, isn't this interesting? So they did next generation DNA sequencing on bladder mucosal biopsies to look at what was happening in that tissue. They also looked at how broken down the bladder was and the density of infiltrating immune cells, including lymphocytes, mast cells, and plasma cells. Hunner's IC specimens exhibited a markedly distinct transcription profile with 3,566 differentially expressed genes. Wow. And 116 biological processes, particularly associated with microbial response and heightened autoimmunity. No significant differences were observed in lymphoplasmacytic or mast cell densities, nor in B cells. These findings underscore a unique immunopathological signature for Hunner's lesions, characterized by plasma cell predominance and epithelial denudation, offering new insights into its pathogenesis and therapeutic targeting. Okay, that, my friend, is a good study. to see next generation analyses of the tissue of the bladder. Fascinating. I'm going to have to pay $30 or $40 for that paper to read it because it is not free, unfortunately. All right, let's look at this other study here. Intravesical instillation of a nerve growth factor ameliorates acute IC related frequency in a rat model. So our bladder therapies for our bladder wall-driven phenotype have typically been coatings like chondroitin or Elmeron or heparin. The goal behind that coating is to just kind of protect the bladder wall. Now, DMSO is an old treatment that we really don't do very much anymore in favor instead of the rescue installations. But DMSO has more methods of action. It kind of gets deeper into the tissue and it does a lot of stuff that they don't quite understand. So it's kind of, I don't know. I mean, I did 8 DMSO treatments, did nothing for me, but it hurt. So I don't think DMSO is particularly viable therapy at all, but that's just my opinion. And I can just tell you that it's an old therapy that is not being done so much anymore in many clinics in favor of rescue installations. Most importantly, when you have a DMSO installation, it's painful. It can hurt badly. Whereas if you have a rescue installation, you generally walk out without pain. And so patients prefer to walk out without pain rather than to walk out in pain. So this study, they hypothesized that putting a nerve growth factor to downregulate nerve growth expression would alleviate neuroinflammation causing urinary frequency. And let's see, when they did that, they had a 20%, 26% increase in nerve growth expression in IC rats, particularly in the urothelium. Whereas the intravesical antisense therapy, the anti-nerve growth factor, reduced levels by 28%. So it's an anti-nerve growth factor therapy to calm the nerves down. So that's very, very promising. That looks good. We're going to need human studies on that. They're just doing animal studies on that. That is fascinating. Now, I know that I saw, hold on a sec. Okay, October 18th. Okay, now we've got 5 more studies. The first one is a positive response to therapeutic hydrodistension in ICBPS. Let's see what the hell that's all about. The objective of the study was to assess the duration and clinical correlates of a positive response to a hydrodistension. 124 women were enrolled in this study. They were assessed for their symptoms before the hydrodistension, then after the hydrodistension, that was then treated 1, 2, 3, 6, 12 months post-treatment. Okay, at 1 month post-treatment, 54% of patients felt better, and 43% felt better a year later. So they consider a therapeutic hydrodistension to be a clinically meaningful treatment for IC for some patients. However, they say having higher scores, or if you have widespread pain, non-bladder-centric phenotype, that you're not going to have success with it. Okay, look at that. And where was this study done? Wake Forest. Wake Forest. Laura's seeing if you have time to answer my questions. Yes, honey, just go ahead. I'm just waiting for questions here. So while I'm waiting for questions, I'm going through some of the latest research. But if we're done, and that's fine with me. All right, here, hold on a sec. All right, hold on. I got so many windows open right now. Yikes. Okay, the role of clinical nurse specialists in the management of patients with bladder pain syndrome. Okay, let's see what this one is. Bladder pain syndrome is a complex and chronic condition with, okay, God bless America, honey. Oh, no wonder. It's from the United Kingdom. BPS can have a profound effect on patients' psychosocial well-being and quality of life. Clinical nurse specialists are core members of the doctor's team that care for patients. Okay, yeah. You're saying that nurses play an important role. I agree, they do. Let's move on. Oh, this is very interesting. The quality of IC information online produced by AI. So here's a research team from Victoria, Australia, who were evaluating patient education materials derived from AI sources. And information quality was moderate, with Perplexity performing the best. I've never heard of that, versus Bing AI the worst. Responses from AI to IC questions was college level readability, limiting accessibility. Misinformation was fairly minimal. Okay. So in other words, AI is getting some of it right, but it's too academic for patients to understand. Okay. That makes total sense. All right. Laura says, I have levator ani. Will I ever have normal bowel movements after having physical therapy? Yes. I mean, you just have to understand that bowel movements, I mean, there are it's multifactorial, hun. So the challenge with levator ani syndrome is that your levator muscles are so tight, it's hard to relax enough to release bowel movements, which sucks. And so doing that physical therapy to try to get these muscles as healthy as possible is very, very important. Learning how to do your internal work is very important. I always know when my muscles are starting to get tight because I have rectal pain. I mean, I'll start feeling pain when I'm sitting down. It will feel like it's rectal pain, but it turns, when I put my finger back down there, what it is my rectum is fine. It's the muscles about an inch to the left, an inch to the right. The muscles in your butt cheek right there are the ones that are very, very tight and sensitive. And that's when I get my wand out and I work on my muscles myself. And as soon as you start feeling any of that muscle tension, getting that wand out is very, very useful. In the same sense, we also have to understand the nature of and the other fundamental contributors to good bowel movements. And that means, number one, a woman needs 20 to 25 grams of fiber a day to have a normal bowel movement. If you're eating less than that, it's going to be a lot harder. So I went through a period of time where I had a lot of rectal pain, and I'm telling you right now, I was passing hard rock poops. It's just like, wow, very, very uncomfortable. And little hard rocks. And sometimes as those rocks were passing through, they would push on nerves and I would get leg pain. So I had an appointment with an IBS specialist, and it was, to this day, the best doctor's appointment I'd ever had. She spent an hour with me. And we went through a bunch of stuff along with central nervous system, stuff like that. And then she just said, Jill, how many grams of fiber do you eat a day? I went, I have no idea. Nobody has ever asked me that question before. And she said, you need to have at least 20 grams of fiber a day to have a normal bowel movement. And I said to her, I'm sure I am. I have a great diet. And she said, well, I want you to go home and look at the labels and count up your fiber, which I did. And when I counted up my fiber, you know how many grams of fiber I was eating a day? 6. Like 2 pieces of toast with half an apple or an apple. That was it. Not enough fiber. And she gave me a fiber list. In fact, I've got articles on it on the website. In fact, I should put it in the book. That talked about the levels of fiber in food. So if you think, for example, you think eating a salad has a lot of fiber, wrong. 1 cup of lettuce has 1 gram of fiber in it. I was eating a lot of salads back then. In contrast, 1 cup of green peas has 13 to 16 grams of fiber a day. And so I use this fiber list to just try to balance out my diet more effectively. And I can still remember, I mean, I had always had such pain because I had IBS. I had always associated bowel movements with pain anyway. And once I got the fiber intake up, it was like, oh, it doesn't hurt. Oh, this is weird. Oh, look at that. A normal natural urge to go to the bathroom. And by golly, it didn't hurt at all once I got the fiber up. So my secret weapon is green peas and white beans. And so I try to have a couple of servings of green peas or garbanzo beans or white beans every other day. Now, sometimes I go a little too far, and then I pay for it. But anyway, that's my goal. You know, it's just getting old is weird. Very, very weird. It's like I've lost my muscles and now I have this. Like, where did that come from? Okay. So what's on my plate? Writing. My goal by the end of the year is to have our winter IC Optimist done and to have the new diet guide done and to have our new medical journal done. So I am working with patients every day. You are absolutely welcome to call the IC network. You can call Monday through Friday. I'm the person answering the phone right now most of the time. So people are always surprised when I answer it. They go, wait, you're Jill. Don't you have a secretary? It's like, I don't. You are welcome to call. And if you don't get me, just assume that I'm working with somebody else. I have some days when I'm on the phone. For last week, 2 days, I was on the phone 7 hours a day working with patients. A lot of patients sign up for coaching, and some don't. And that's okay. I mean, if you have a couple of questions, you just want to talk to somebody, feel free to give me a phone call. It's absolutely fine. A lot of people say, well, what are your credentials? Well, I have degrees in chemistry. I have a degree in pharmacology drug development. I have a master's degree in psychology. I was working on my doctorate in psychology when my IC began, which obviously means that I couldn't finish that. The IC network was my doctoral dissertation proposal on how to bring support to patients who were homebound. The IC network has been rated in the 2 peer-reviewed studies as the best website on IC, most accurate, reliable, credible. I'm not just a writer, I'm a researcher. I do a lot of IC research now and collaborate with a lot of other people. So a lot of other researchers. I also speak on IC extensively at conferences and, with media outlets and things like that. So, and most importantly, the National IC Support Group leader. Understand that the IC support system broke down during COVID and it is not back. There might be one or two groups that are doing little meetings on Zoom, but there are no more consistent support group meetings except ours. I hope we can attract more support group leaders back to the IC movement, but it's looking pretty bleak right now. My goal is to work for another 5 years and then pass the IC network off to somebody who might have an interest in it. I have one person in mind potentially. So get me while you can, my friends. I am more than happy to help in any way. If you find these meetings helpful, please come on over to the IC network. You can become a member and get our magazine. This was our latest magazine. I also happen to think this is probably the best magazine we've done in 20 years. The lead story is the tragic and tarnished history of Elmoron. And also American Urology Association, all sorts of stuff like that. So when you sign up to become a member of the IC network, you get our magazine and a bunch of other freebies that you can download from your member page. So you can become a member in the IC network shop. What I don't want you to do is feel like you've got to pay somebody $500 a month to learn about IC. I'm telling you right now, we have the best information on IC. According to doctors, IC network is taught in medical schools to doctors to refer their patients to. Our website is entirely free. You don't have to pay anyone to learn about IC. Please watch our masterclass. I have a great video series, an IC 101 masterclass now that you can watch right on the IC network website. And it will answer lots and lots of questions. Most importantly, it will help you understand phenotypes and trying to find the right treatments for you. Because my personal goal is to find those patients who were all told years ago they have an incurable bladder disease, who have been living with pain for years with no hope. Because we have tremendous hope now. Now that we can phenotype, we can identify underlying causation and fix the underlying cause. And that's always going to be our goal. So, all right, guys. Well, listen, I think we're done. Been here for 2 hours. I hope you all have a great Sunday. Feel free to call tomorrow. Be the squeaky wheel. You have my permission to email and call over and over and over again. And I didn't do a freebie. I do have a freebie I could have given, but I forgot to do it. So we'll do it next time. So I'm going to say goodbye. See y'all later. Have a good rest of the evening. Bye, YouTube.